Good afternoon to everyone on the line. Welcome to today's webinar presentation. My name is Maria Nuesi and I will be your host and moderator. We are very excited to have all of you with us today for a presentation on using simulations with virtual patients for clinical practice hours. Today, I am joined by two experts who will share how schools of social work, nursing, and medicine are using simulation technology to supplement curricula, implement distance learning, and replace lost clinical encounter hours. However, before I hand it over to them, I'd like to go over a few housekeeping items. The first is that today's session is being recorded, so please don't worry about taking notes. We will send you a copy of both the recording and the slides after the presentation. Attendees will also be provided with demo access to the simulation that will be demonstrated today. The second piece is that during the presentation, attendees are in listen-only mode. However, we have a lot of time for questions at the end, so we encourage you to use the interface on the right-hand side of your screen to submit questions. And so to get us in the right frame of mind for today's discussion, I'd like to invite attendees to turn over to their screen for a quick poll question. And the question is, how has your program adjusted to the loss of clinical hours? And your choices are, we have already incorporated virtual practice. We're currently evaluating virtual practice options. We have not started evaluating alternatives, or not sure. And I'm going to give you a couple of seconds to respond before I share the results with everyone. Great, so it looks like the majority of you, 47%, are evaluating virtual practice options, 37% have incorporated, and 16% are not sure. So hopefully today's discussion for those that are in the evaluation process can inform some of the decisions that you continue to make throughout the academic year. So with that, I want to introduce our presenters for today's discussion. I am joined by Dr. Shauna Aquavita. She's an associate professor and MSW director at the School of Social Work at the University of Cincinnati. She has a decade of social work experience working with individuals who have been diagnosed with mental health and substance use disorder. And I am also joined by Gurnik Singh. Gurnik is the head of healthcare products at Kognito, and he specializes in the application of digital innovations to improve healthcare delivery, reduce staff burden, and drive patient education and engagement. I want to welcome both and turn it over to Dr. Aquavita to get us started. Thank you.
Thanks so much, Maria. Okay, next slide. So just a little bit about what I'm going through here at the University of Cincinnati. We've had some challenges with students completing their components for their degree, as I'm sure a lot of programs have. So the question has been, how do we engage and stimulate learners who have transitioned to online learning? So I've had previous experience with Kognito prior to COVID-19, and now we've added on to other courses to provide a variety of learning options. And so I'm going to share some of the things that we've done pre-COVID and now currently during this time. Thanks. Next slide.
Good afternoon, everybody. My name is Gurnik Singh. Thanks, Maria, for that great introduction. I am the head of healthcare product at Kognito, and I get to build virtual human simulations, which is actually quite a lot of fun. I enjoy my job quite a bit. And our goal is really to prepare health professions students to lead effective patient encounters in real life through the use of our simulations. At Kognito, we've spent the better part of the last decade developing, studying, which is key, and delivering evidence-based simulation training. So I'm going to briefly describe virtual human simulations and the training simulations that we build before I pass it back to Dr. Aquavita to talk about how she's using Kognito simulations in her program, and some of the issues that she's dealing with the current environment. And then hopefully we'll have some time later to actually go in and play one of our simulations to give everyone a deeper insight into how exactly these work. So virtual humans themselves have proven to be excellent subjects of practice. Study after study, and this dates back into the early 2000s, have shown that people, all kinds of people, race, gender, age, profession agnostic, like interacting with virtual humans. Participants in these studies report feeling less judged compared to interactions with live persons, and freer to express themselves honestly and experiment in the interaction, which is obviously of significant benefit to learning, to be able to play with options in a consequence-free environment. So virtual humans offer us as trainers and educators exceptional control in delivering practice that focuses on very specific skills with measurable outcomes that can be reproduced with perfect fidelity for every single learner. Next slide, please. Kognito's virtual human simulations are web-based and designed to be self-directed. So learners can engage and practice an encounter on demand from anywhere, from a mobile device, laptop device, when it is most relevant to them, whether that's for curricular purposes or clinical encounter hour purposes, or simply as preparation before virtual standardized patient practice, for example. In the experience, learners meet an AI-powered virtual human that has a unique persona, adaptive memory, and a real human voice that supports verbal and nonverbal emotional responses, which is really key for giving a realistic experience. In addition to the reactions of that virtual patient and the dialogue that you encounter through the course of the conversation, there are several dynamic feedback mechanisms that give each learner critical instruction throughout the training to understand how to effectively manage this conversation and what are some ineffective techniques, mistakes, pitfalls that you want to avoid. The coach feedback helps learners understand those ineffective and effective choices as they make them, so really at the point of most interest and deepest element of learning. The engagement meter helps learners track how well they are maintaining rapport and engaging the patient holistically so that they can produce honest responses and achieve their encounter objective. And periodically throughout the experience, we will also allow learners to hear inside of the patient's thoughts to understand their perspective as they navigate sensitive or challenging conversation topics, which is really essential in order to understand how to approach someone who may be feeling vulnerable by trying to give you an honest answer. Next slide, please. At the end of a simulation module, the learner receives a personalized dashboard with quantitative and qualitative feedback. An overall score rates their holistic performance, while goal-specific feedback helps each learner identify their strengths and areas for improvement along the lines of their achievement and for the specific learning objectives in that encounter. Next slide, please. So to build the simulation experiences, we marry our expertise in instructional design and virtual human technology with clinical and communications trainings expertise from subject matters who are at the top of their fields. So we work with subject matters from leading institutions throughout the country to pressure test simulation scenarios for realism and contribute to the instructional design by guiding the application of evidence-based and best practices to the communication training experience that we're building. In addition to those clinical experts, we also work with patient advocates to ensure a realistic experience from the patient perspective. So our development process will allow us to capture and incorporate real-world experiences, stories from people who have lived these conversations to build realistic encounters. And one example I will cite is working with the CDC in the development of one of our simulations. They gave us access to women who had survived breast cancer. And we interviewed 10 plus patients to get their experience of that first encounter when they're diagnosed, the things that they wish they knew going into the meeting, some of the realistic things that happened to them that were unexpected that they wanted to share in terms of wisdom to other people who are going to be engaging in this conversation for the first time. So that's the type of rigor, the type of expertise that we bring to bear in the development of each of these simulation scenarios. Next slide, please. And so we have applied this instructional design expertise and approach to several key areas within clinical practice to offer dozens of training scenarios. So learners can gain practice in behavioral health, pediatric and chronic disease cases, while also experiencing virtual patient interactions in an array of settings. So whether it's ambulatory care, inpatient care, in-home settings, or our recently added telehealth environments, we want to expose learners to a broad set of realistic experiences that they may end up having to utilize in their professional experience, or will have direct impact on the curriculum and practice that they're going through in a specific course during their training. So we have also developed practice scenarios that help learners develop essential soft skills to effectively work and collaborate with their colleagues as well. So not just how do you engage patients, but also applying best practices for interacting with your colleagues, whether they're superiors, other members of your care team, et cetera, to figure out how to manage conflict and collaborate in an effective way. So our team will be more than happy to share our full training catalog with you at a later date to kind of look at more granular level of detail. But at this time, I'm going to pass the baton back to Dr. Aquavita to tell you about her program's experience using Kognito and the ways virtual human simulations are helping them adapt to the current environment.
Thanks so much, Gernick. So right now I am the MSW director at the University of Cincinnati. And so the social work program, as I mentioned, is experiencing some challenges in regards to how to handle placements and that sort of thing. So getting clinical hours can definitely be an issue, as well as trying to figure out how to engage your learners online in kind of active learning. So next slide, please. So I'm going to talk first about how I used Kognito prior to COVID-19. And so I actually had a grant that I was able to design an interprofessional course on screening, brief intervention, and referral to treatment. It was a course with the College of Nursing, Medicine, Pharmacy, and Social Work students. And so we had it partially asynchronous with some specific information that students had to take on being trained in expert. And then we had an opportunity for them to use Kognito for a module on adolescents. So next slide, please. So the specific adolescent module, what we did was we accessed IRETA online adolescent module, which you can access, and it has specific information on how you implement expert with adolescents. And then we paired it with the Kognito online simulation. We had students take that after they've completed the module. And so students were able to take this module and then learn how to implement it. And so this was really helpful for them because they learned the material and then they actually got to implement it. They saw what it was like in a virtual area. And so just some of the feedback we got from students were, I found these tools most useful because Kognito trainings allowed me to practice with clients in the age range I currently work with, which are youth. And I work with high schoolers, and therefore I found the module on adolescent substance abuse to be the most relevant to my work responsibilities. Next slide, please. So what I wanted to show you all was we took a look at those students who actually use the adolescent module. When we designed the course, we allowed students to take the course for 2 credits or 3 credits. So those students who were taking the course for extra credits took the adolescent module as well. And so just to give you some information, over the course of the 3 years we had with SAMHSA, we created that module, and then the students who took the 3 credit course took this module. And so we had approximately 78 students who took it, and you can look at the demographics, medicine, nursing, pharmacy, social work, and how many hours of prior substance use disorders training they had, and if they had prior motivational interviewing skills. So next slide, please. So what we examined then was how they felt in regards to being professionally competent in performing these alcohol and drug-related aspects when working with an adolescent. So this the Kognito module actually went through and helped train students how to do these things, like how do you ask adolescents about their alcohol and drug use? How do you ask about the quantity and frequency? Screenings, adolescents, discussing and advising, providing professionalized feedback or personalized feedback, how to tailor brief interventions, helping adolescents to identify benefits of cutting back or stopping, helping adolescents identify challenges and barriers in cutting back or stopping use of alcohol and drugs, and helping adolescents develop a personal plan, as well as engaging parents. And so what we found was that there were significant results on how professionally competent they felt from before and then after. So I think it's pretty significant that we were able to demonstrate that they felt much more comfortable after using this adolescent module. Next slide, please. And so we looked at also how likely the students were to conduct substance use screening, brief interventions, and referrals to adolescents. And so we had 52 participants respond. And so most of them were very likely or likely to be able to conduct these substance use screenings. And then their confidence in their ability could say that they strongly agreed or agreed, which is also demonstrates how effective this can be for students. Next slide, please. Then we followed up 30 days later, and so these are just some of the things I wanted to share. One student shared, I just graduated with my social work degree, and no matter what area I end up going into, I will encounter substance use issues, so the section about expert with adolescents applied to what I hope to do. Another student said, I work with teens and some of them have experienced substance abuse issues. It is helpful to use this class as a resource when working with these adolescents. Another student said, the use and practice of motivational interviewing has helped me in adolescent interventions. So this was just some of the feedback that we got from students on this module. Next slide, please. So moving forward with COVID, we had to move all of our classes online, which I'm sure a lot of your programs, if you are teaching in allied health, you understand that that can be pretty challenging. And so being able to engage these students, we decided that we were going to try something different. And since we'd used Kognito in the past and we knew what services they could provide, and they're able to give us some feedback about how our learners do, we decided to contact Kognito, and we got to look at different modules that we thought would work well in a course that we were teaching. This is a course that we use for students who are in an accelerated program, a one-year master's program. They have a bachelor's in social work, and so they go into the master's program. And so this is a bridge course we used. And so we use the at-risk in the ED. We also decided that we would use at-risk in the ED for a individuals and families course that we have, and that is for the first year MSW students who are in the 2-year program. And so what's really helpful is that both teach motivational interviewing and screening components. But I just want to share with you a little bit about the assignments that we're working on, or we did work on with these students. So the one that happened over the summer, the bridge course, we created an assignment with this simulation. So what we did was we had them complete the simulation, and I'm just going to read a little bit about what we had them do. Each student will be assigned a simulation. Through review of the case, select 2 theories that could be used to inform your practice approach and compare and contrast these theories. Describe what information would be gathered for assessment and using self-reflection. What might you need to be aware of as yourself when engaging this client? What practice principles might inform your work with this client? How would you approach preliminary joint planning and goal setting with this client, and identify several resources you might consider offering to the client and give reasons for these. And this was a paper. So I want to say that the simulation can be used standalone as well, but you can also create an assignment. You can discuss it in class with students. So there are things that you can do with this assignment to really create a great learning environment. Next slide, please. So these are just some survey results from the at-risk and the ED that we had from the students. And so you can see a majority of them felt that they were pretty confident in their ability to screen patients for behavioral health concerns using valid instruments post-survey. They felt confident in their ability to initiate a conversation with a patient about their behavioral health post-survey. They felt confident in their ability to use motivational interviewing and motivate a patient to seek behavioral health treatment. And that was a post-survey, a significant result. And I feel confident in my ability to schedule a follow-up visit or refer patients to additional behavioral health treatment or support services. So you can see majority of the students agreed that, and there was a percentage change in those. Next slide, please. So I just wanted to acknowledge some people who contributed to this, including the funder for our previous course. Next slide, please. And I will turn it over to Gurnik. Thank you.
Yeah, that's great. Thank you, Shauna. I really appreciate you sharing all that insight. Now at this time, we will take an opportunity to actually look at one of the simulations. This simulation that we're going to demo for you is really focused again on screening and brief intervention with adolescents. This simulation is not only utilized by schools of health professions across the board, in addition to social work programs, nursing schools as well as medical schools are using this tool, and it's been used to train practicing professionals as well. It's accredited for CME, CNE, and NASW contact hours as well. And the purpose, again, is to screen and conduct a brief intervention with an adolescent patient who has come in to your ED after having fractured his ankle, falling off a roof after a long night of drinking. So let's go ahead and see how this conversation is going to play out. So I'll introduce you to our menu structure first. So in each simulation experience, learners are going to be introduced to the topics that they're going to be evaluated against. So in this case, we cover background information on screening, brief intervention, and referral to treatment, exemplify the techniques that are used in order to lead an effective screening and brief intervention conversation, and then provide an opportunity to practice 2 role plays with different virtual patients. So each of our virtual conversations are designed to emulate a real life conversation, so they last no longer than 15 minutes. Now, because of all of the different pathways a learner can choose, we find, in fact, that they'll spend upwards of twice as long really exploring, understanding what's effective, what's ineffective, making mistakes on purpose to learn from all of the different feedback mechanisms in the simulation. And then after going through the practice, there is an assessment challenge where we remove all of the feedback mechanisms and evaluate that learner against how well they can actually execute this with the guardrails taken away. And at the end, they get a score report. So we'll go ahead and take a look at the practice conversation just to get some exposure to the ways in which these work. It'll start off with some introduction, just laying out the scenario and the case for you. We provide sort of one quiz question just to make sure and check that the learner reviewed all of the didactic information before jumping into the practice convo. And we'll apologize ahead of time if there's any lag. Usually that's just due to the webinar software. Again, all of these mobile and desktop enabled simulations will play speedily on any device.
This portion
just may experience lag to the webinar.
Practice providing a brief intervention by speaking with virtual adolescents. Each brings his or her own story, personality, and emotions to the conversation, reacting to what you say the same way a real adolescent would, and challenging you to tailor your approach to their specific situation. I'll be around to give you feedback throughout the process, and you can use the BI checklist on the bottom of the screen if you want a reminder about the steps of the brief intervention. Let's get started.
So that's our coach. She's going to be available to provide us all kinds of feedback as we navigate this. We set every scenario up with the relevant information in the form of medical history so that the learner has a baseline of where they want to take the conversation. Click continue. And then we have our knowledge check just to ensure that they're starting off having read and evaluated the preparatory materials?
Hi, Josh.
Now we're going to dive into the scenario.
Nurse Lopez mentioned.
Yeah,
How are you feeling?
well, I've been better.
Oh, I'm sorry to hear that. Mind chatting with me while we wait for your x-rays?
I don't know, I'm pretty slammed today.
So, yes, you can talk?
Yeah, sure.
So
All
just
right,
to
and so the coach sets us up, directing us where we need to go.
fun.
Well, you know, there's like nothing to do in this town. I hang out with my friends.
What kinds of things do you do when you hang out?
We chill, play video games or whatever, some pickup football.
You like to play video games and football with your friends. Are you on the school team?
Yeah, next year I should go varsity.
And now we, as the learner, get to take over the experience and guide the conversation. So the coach is there. The menu options are there to help remind us what our purpose is. Again, as a learning experience, we want to give that individual as much structure as possible in order to learn the foundations for navigating this conversation. And then we'll take over by selecting options from the talk menu. So when we click on the talk menu, we'll see a few different tactics populate. The tactics are, again, based on the feedback that we've already learned in the didactic videos. So we know that we're supposed to build rapport. And probably the best way to do that is by asking Josh about his life. But let's go ahead and just give advice and see what happens if we don't follow the coach's instructions.
On the form you filled out, you said you regularly drink.
And here comes the lecture in 3, 2, 1.
I don't want to lecture you. It's just really dangerous for someone your age. I mean, look at what happened today.
Oh my God, you're right. It'll never happen again. I'm so glad you were here to set me straight.
So Josh reacts like our typical teenager, not wanting to get spoken down to. And the coach comes in to really help us understand what happened, why things didn't play out like we might have expected. And again, the key is to reiterate using open-ended questions to learn about the situation and making sure that we'll ask permission. And so in this instance, the learning experience is telling us that we have to undo this decision point because, in fact, going down this pathway right away is going to inhibit us from getting an accurate screening and conducting the brief intervention. So we're forced to undo that decision, and it takes us back to where we just were so that we can make a more informed decision that follows along with the guidance. So if we look at those talk options again, we'll notice that the tactics have changed. We no longer can make that mistake, and now we are given the opportunity to correct our previous error. So let's go ahead and ask about his life and see how this conversation plays out.
Kind of an interesting night. How did you end up on the roof?
I already told the lady at the desk. Doesn't your form or whatever have that?
Well, I'd like to hear it from you.
We were hanging out at a friend's place partying, and some of us got in the hot tub. And I thought it would be cool to, if I could jump in from really high.
Okay. And when you say partying, what do you mean?
Drinking a few beers and having some fun.
So the coach pops in now, again, to reinforce the positive decision that we've made to use an open-ended question, and not just one, but a series of open-ended questions to try and continue to break down some of those barriers. We see that Josh is reacting like a normal teen, still with some hesitancy, but at least this pathway has given us a little bit more information. So let's go through one more decision node and see some of the other features pop up. So again, we'll notice that our tactical options have been modified a little bit. And so let's go ahead and continue to ask about the party and see if we can uncover other key elements to help us conduct the screening.
Tell me more about the party tonight. What were you doing before you hurt your ankle?
Drinking and goofing around.
How much did you have to drink tonight?
A 6-pack?
How typical is that for you to have 6 drinks?
Well, I guess tonight we partied pretty hard. We won our football game on Friday. The team usually parties together after a game, and when we win, that makes it even better.
Were you using anything else at the party? Any other drugs?
Nah, it's just drinking.
So we see now some of the additional feedback mechanisms. The engagement meter has gone up to let us know that we are starting to build that necessary rapport. And in the course of those those questions, we actually got some critical responses for our screening tool. Let's take a look now and see what happened with our talk options. They have, again, evolved, and so these series of options will continue to branch and alternate to allow us to have sort of an individualized experience as we go through this. So again, we were told that we're supposed to ask permission before we dive into this critical subject. So let's go ahead and select the first option and see what happens.
I noticed you filled out the questionnaire about alcohol and other drug use. We ask all of our patients to complete that. Thank you for being honest on it. I'd like to talk with you for a few minutes about your responses. What do you think about that?
Oh, okay, I guess.
And so here again, we see a new feature where the inner thought allows us to get the patient's perspective and understand what they may be thinking as we're trying to travel down this course of questions.
I didn't think anyone would look at that thing. Maybe I shouldn't have been so honest.
So again, we want to impart on our learners that it's critical to understand the patient is feeling vulnerable and concerned about the implications for their honest responses. And that should inform your decisions as you travel through the rest of the conversation. So I won't spoil the end of this. Everybody will have an opportunity to navigate these with the demo that we send out after the webinar. But I do want to navigate back to the menu and just take a look at the score dashboard that we see after completing the assessment piece. So we went ahead and completed this earlier, and we didn't do so great. Our motivational style is pretty low. Our engagement level is really, really low. And overall, we got a fair score, probably because we ticked the box on a number of our key objectives, but we maybe didn't do them as successfully as we would have liked to. So if we scroll down, we see that we're getting feedback on each of the individual components of the engagement that we were supposed to demonstrate and learn some skill around. And then in each of those sections, we get specific feedback that is targeted to our performance in this conversation itself. So there are a couple of different places you can net out in terms of points and performance. And in doing so, we'll get our own qualitative feedback that's specific to how we've done. And if you come back and complete the simulation again, you will see, obviously, you'll get different feedback performance based on your decisions in the course of that conversation. So with that, I think we'll open it up for some Q&A for our last 10 minutes and see what other kinds of questions you have, what we can answer.
Thank you so much, Dr. Acquavita and Gernik, for sharing with us. And as Gernik said, please submit your questions using the question box. And for those of you, a few of you have already asked about the recording, we are going to be sending you the recording and the slides within 24 hours of the webinar ending. So the first question is for Dr. Acquavita. We saw from the poll question that 47% of attendees today are in the evaluation process. Can you share with us what it was like, sort of the implementation of the simulations into the curriculum, what steps you took to get up and running and have this in the hands of your students?
Right. So what we did was we looked at two courses that we knew we would need something around motivational interviewing. And I knew that Kognito already had some specific simulations around that. And so we just looked through that. We decided that the one that we chose, at risk in the ED, would encompass a lot of different skills, and it would be used kind of more towards the end of the course so that all the things that we were trying to cover could be evaluated by the simulation, but also for students to be able to write about their experience. So I think that we were able to do that because we have great faculty who work hard, and they were really trying to be creative. Normally we talk about different cases actually in the class. We have specific cases that we get students to share, but we knew that some of the students wouldn't have access to their internship yet. And so we were looking for a case that everyone could discuss and understand. And so this was our opportunity to do this. So it was really we decided, I think we paid for the simulation in May, and this was implemented in June. So that was a quick turnaround for this.
Great.
That was, yeah.
Thank you. The next question, Garnick, it looks like we have folks from nursing program as well. Can you speak to the variation in content that is tailored, whether you are in a social work program, nursing, or medical school program?
Yeah, sure. If we could actually go to the next slide, I have a couple of other use cases here to share to help maybe exemplify that a little bit. So a number of our nursing school clients have used a variety of our simulations targeted to nursing practice. University of Michigan School of Nursing used our SBI with Adolescents simulation with a nursing avatar experience for their mental health and illness across the lifespan course, and they utilized the simulation for 2 hours of clinical practice. They also combined it with our SBI with Adults simulation. That is another assessment tool that they used to actually provide a passing grade to students based on their qualitative score there. And the outcomes from that program, overwhelmingly positive. The nursing students had 68% increase in competency level from pre to post, as well as 58% increase in self-efficacy pre to post. In addition to the behavioral health simulations, they also use our chronic disease conversations, which are significantly lengthier. That's about 3 hours worth of practice where you're engaging with patients who are living with chronic disease, whether it's hypertension, diabetes, they have experienced CHF, and they're coming in and it's up to you to identify what's going on in their day-to-day life and motivate them to adhere to a care plan. So there are a number of different simulation pieces used in schools of nursing. And if we jump to the next slide too, there's another case example from a medical school. Geisinger is using a number of our simulations, including our cultural competency simulations around LGBTQ community members. And so one of the simulations there, the students, after completing the simulation, had indicated 90% of those learners rated themselves as agree or strongly agree to be confident and using accurate and informed language when discussing issues of sexual orientation and gender identity. So we've got a number of different ways in which the variety of our simulations are being applied in curricula across the schools of health professions.
Great, thank you. So the couple of questions have come on around pricing. So Gernick, I don't know if you want to give some high level information and maybe to follow up offline in terms of the cost of these programs.
Yeah, we're happy to provide some individual pricing. It works a little bit on a case-by-case basis in terms of the number of students that you ultimately have to train and the number of simulations. But I think a base case is on a per user basis for access to a suite of simulations. The price will usually run from $60 to $75 per student. But again, that can vary based on the number of students, the number of simulations that you want to utilize.
Awesome. And I see one last, here we go. Another question is, as a student using these simulations, I know that there is a coach that will give you feedback, but is there a way to get feedback directly from a professor or have the professor view your simulation so that they can provide their feedback as well? And I will open it up to both Dr. Acquavita and Gernick to provide insights on that.
Yeah, maybe Dr. Acquavita, if you want to talk about how you've utilized it in your courses, I can give a couple of examples as well.
Well, I'm also going to share, because we use this for an expert training for teachers, and we actually had the trainer go through it and had the audience kind of choose what they wanted to do, and they could go through it that way. So that's how we've done it. We have gotten the score, and then we've added it to the student grade. We've had an opportunity for students to process it with us, but that's the only opportunity that we've had to actually go through the simulation like we kind of did just right here, and then talk about the different options and why we would do that. So that is one way to do it.
Right. So the blended learning, I think, is a really common way to incorporate the simulations into curricula where, because there are multiple modules in a given simulation, you may use one of the practice ones in the classroom to facilitate discussion. So, pushing the class to help you identify what's the right path, asking preemptive questions about what the implications might be for a particular mistake or pitfall that you choose to utilize. So the blended learning approach is very common where the practice simulations can be incorporated in the coursework, in live sessions in class, and then the assessment challenges can be assigned to demonstrate competency after having gone through the lesson plan.
Great, thank you. And I'm going to ask a couple more questions before we're out of time. This question is, with technology being a big part of the 12 grand challenges for social work, software and programs like this are instrumental. The question is, how soon can we expect to get a demo so we can try it out for ourselves? So again, within 24 hours, so the latest by tomorrow afternoon, 3 p.m. Eastern time, you will have links to the simulation that was demoed during this webinar, and maybe a couple of others, as well as the recording and the slides from the presentation. With that, I actually want to invite, while other last minute questions come in, Dr. Acquavita to share. I know this time of the year is definitely in flux. Things are changing every moment. Is there any advice, again, for that 47% of individuals who are on the call today that are still in the evaluation process that you can share?
I would say just really look at what options there are for you through Kognito. There are a lot of different programs that you can do that we were considering, and where it'll fit into your curriculum. And you can give it to students just as, here's your assignment, and then you can have an assignment around it. You can have class discussions. You can have it count towards clinical hours. And then do an assignment around that. You can debrief with them. There is just a lot of things that you can do. And what's so nice is that it's standardized. And, oftentimes when we work with students, we hand them a case and they read it. And so this is actually engaging in it. And I think it takes it to a different level, and students feel much more comfortable with that than going in after that and seeing clients. Or we used this and then we did a standardized patient experience. So we kind of used scaffolding for the learning. So they had this simulation and then they had a standardized patient experience for one of the courses that we did. So I think there's multiple ways that you can do it. And there's just a lot of opportunities. So.
Maria, I don't know if you're muted, but.
Thank you so much. So I want to thank Dr. Acquavita and Gernick for spending the last 45 minutes with us and sharing this great content. And for all of you that tuned in today, thank you and good luck with the academic year. We will be following up with you with all of these resources, and stay tuned for our next webinar in the coming weeks. So take care, everyone. Stay safe, and we'll see you around.
Thank you. Thanks for
so
joining.
much.
Good to talk to you.